This is Selma Schimmel in Chicago for the group room. We're at the 2012 Multidisciplinary Symposium in Thoracic Oncology, which is brought to you by ASTRO, IASLC, ASCO, and the University of Chicago. We are now joined by Dr. David Ball, Chair of the Lung Cancer Service and Deputy Director of Radiation Oncology at the Peter MacCallum Cancer Centre in Melbourne, Australia, and also Professorial Fellow of the University of Melbourne. I was reading in preparation and speaking with you that stage 1 non-small cell lung cancer patients who receive radiation therapy are surviving longer, but how shocking the percentage is of patients that are not receiving their treatment remaining as high as 16%. And you told me that this is actually an international problem. This is not limited to the US, that on a global level, this access to treatment is low.
The standard of care for stage 1 disease is surgery. That's well established, but there are a large number of patients who are elderly or they have other diseases related to their past smoking habit, which may be cardiac disease or emphysema, so they're not fit for surgery. So they come to the radiation oncologist as an alternative treatment. We think that it may be, in some cases, as good a treatment as surgery, but that needs further randomised trials to establish that. Many patients, if they're regarded as not fit for surgery, they're treated nihilistically and they're not offered any treatment. Sometimes that's a patient decision because they are genuinely too unwell. A small stage 1 lung cancer may be less of a threat to a person's life than very severe emphysema or very severe heart disease. But we do know that not only in the US but in our own country, up to 20% of patients receive no treatment after a diagnosis of lung cancer. And this, we think, represents the nihilistic approach to the disease that some physicians still have, that they're not familiar with the advances that have happened. But we also worry that it may signify a degree of stigmatisation of patients with this disease. I can't think of any other cancer where 20% of patients receive no treatment. Even for the nastiest cancers like high-grade brain tumours, glioblastoma, or pancreatic cancer, virtually all those patients would receive treatment. So I think there's something about the attitude to the treatment of this disease that results in a large proportion not getting effective therapy.
Dr. Ball, there was another study presented here regarding the benefits of brain irradiation in regard to lung cancer. Can you talk a bit about that?
We've known for many years that some cancers spread to the brain, and the brain is what we call a sanctuary site. It's a site where chemotherapy drugs are not as effective as they are in other parts of the body.
They don't cross that blood-brain barrier.
Correct. In one of the particular types of lung cancer, the so-called small cell lung cancer, we know that if you're alive at 2 years and you haven't had any treatment to the brain area, the risk of developing a secondary cancer in the brain is about 60%. So you've got more than 1 in 2 chance of failing in the brain. So a number of randomised trials were collectively put together into what we call a meta-analysis, and it demonstrated that you could reduce that figure from 60% to 40% by giving patients preventive brain radiation. Very low doses of brain radiation, which we feel and hope will not cause damage to the normal function of the brain.
The idea of having radiation therapy to someone's brain has to be enormously frightening.
Absolutely.
How do you overcome the emotional obstacle and really the sense of fear, knowing, you know, my brain, my center of thought, that the idea that you would radiate that? How do you approach that discussion with patients to minimize fear and to get them to say, okay, I understand, challenging?
Well, I think the importance of the meta-analysis is that it did demonstrate a survival benefit, and if you wanted to be alive at 5 years, you really had to undergo that treatment. So as with all our patients, we leave the decision with them. We tell them what the pros are and what the cons are. We think that the risk of harm to normal brain function is relatively low, although there are not a lot of studies which have looked at the long-term effects, but in the short term it does appear that it's safe.
Can patients retain their hair?
They lose their hair for several months and then it grows back again. If
So
the
it's
dose
not
is
permanent.
So it's not a permanent loss
That's
of hair.
good.
The study being presented here, I might add, is a slightly different study in that it builds on the experience in the so-called small cell lung cancer, and it applies the same principle that to non-small cell lung cancer. As you know, small cell lung cancer is about 15% of all cancers in the lung. With the non-small cell lung cancer, the rate of secondary spread is probably not as high as it is for small cell lung cancer. We know at 12 months it's about 20% will fail in the brain. So this trial did demonstrate that there is a reduction from about 20% to under 10%. However, that has not been shown to produce a survival advantage. That's in contrast to the small cell study.
What's the difference between small cell and non-small cell, and why are there fewer advances in the small cell lung cancer category?
There's certainly a feeling out there that we've plateaued in what we can achieve. It was the fashionable disease. If you look back at the ASCO meeting in 1990, I think most of the studies would have been on small cell lung cancer that were being presented. Now it's completely the reverse, and I think that's because the mutations which drive non-small cell lung cancer have become so exciting. They've been identified, and we also have drugs which switch off those mutations, which is a fantastic advance.
Dr. Ball, we hope that in the not too distant future there will be opportunities to begin to treat our small cell lung cancer patients as innovatively as our non-small cell lung cancer patients.
Yes, I think there are some developments recognising that these have a neuroendocrine origin, and there's a lot of interest in the way in which we treat neuroendocrine cancers, because they can occur in many different parts of the body, not just in the lung. So there are a family of cancers, and our nuclear medicine people have some interesting new targeted radioactive treatments which hold some promise.
And hopefully we will begin to genomically understand more about the biology and the molecular pathology of small cell.
One of the challenges with small cell is it's a disease which has decreased in proportion compared with non-small cell lung cancer, and previously small cell was about 25% of all lung cancers when I started in this business. Now it's under 15%. So with a diminishing number of patients available for trials, it gets increasingly difficult to address some of these questions.
Thank you. Dr. David Ball, Chair of the Lung Cancer Service and Deputy Director of Radiation Oncology at the Peter MacCallum Cancer Centre in Melbourne, Australia, and Professorial Fellow at the University of Melbourne.
My pleasure. Thank you very much.